Okay, so you maybe a mistake there. I'm not sure. If you do have a question, please ask. Um, Good evening, everyone. My name is Dr. Lopez. If you haven't met me yet, I'm pretty sure you have received tons of emails from me. But if you haven't, welcome to today's event. Today we're starting from the beginning, Module 1, right? Scientific Foundations. Should be about 23 questions, if I'm not mistaken, on this subject. During today's presentations, please feel free to ask a question. I am looking at a different screen, which is the presentation. If you do have a question, go ahead and ask. Definitely, there is no silly questions, right? All questions are important. Also, after the event, throughout the week, email me if you do have any questions or concerns, okay? So that way your questions are answered and you feel fully prepared for the test date. Um, Sharing my screen now and we can get started. Okay. Quick second. I am almost done here sharing my screen. Okay. Is my slide showing? Can you guys see it? Yep. Right. Okay. All right. So today's scientific foundations, it shouldn't be super hard, this topic, but lots of memorization, right? Unlikely culture, unlikely sometimes diagnosed, which is module 3, I believe. You This is more of a memorization topic. So if you go through this, what we recommend is that you finish module 1, you complete question bank module 1. Question bank is located in a different website for now, at least. What you should do is after today's event, you complete all question banks module 1. Many folks will, some people will ask, where's the question bank? We'll answer that question at the end of today's event. We'll go through it together if you still have not been able um, to find the question bank. Okay, so we'll start off by talking about the cerebrum and its parts. So make sure I'm recording this so that way everyone has this available and I can still cut some parts of it and make videos for you guys on YouTube or so forth. Um, Live reviews. We have recorded previous live reviews. So you have not only what's available for for today's event, uh, pre-recorded with myself alone, but you also have a pre-recorded session that has been live before, so that way uh, you can listen to it later or watch some people ask questions. Right, asking questions is very important, and is helpful when we are live. If you can't attend the live event, it's great. If you can't, it's okay. You have all the pre-recorded courses ready for you anytime you want, and that is located on module 10. Understand that's extra, right? It's not necessarily, we have the course itself and a little bit extra, which is the live reviews for you guys to watch on your own. If you think about the cerebrum, right? Think of it as really the CEO of the brain. It coordinates where that's where the 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 lobes are located. It's composed of the biggest part of the brain, 83%. If you divide it in half, right, it would be separated by a line called the sulcus, right? It has 52 distinct parts. You do not have to memorize those 52 distinct parts. Mainly, you have to memorize absolutely the lobes, right? Each one of those 52 little parts is called the Brodmann area. I'm sure you have seen that before, but it's not important. You don't need to know those 52 areas. What's important is that the left and the right cerebrum is, if divided, um, you'd have the left and right hemisphere, right? The left hemispheres control the right side of the body for most people, and vice versa. So if someone has a stroke on the left side of the brain, right, then the right side would be affected. So, for example, the right side is responsible for most facial expression, meaning that if the left was the left side is responsible for control writings, handwriting, for example, and the right side will be more like a functions of the facial expression would be a good example of that. Not super high yield. What is high yield here about the cerebrum? The lobes, right? The lobes of the brain. We're talking about the frontal lobe, parietal lobe, temporal lobe, and occipital. Nothing new here. We'll go over each one of those lobes in a second, but please make sure that you are highlighting and writing down the most important function of each one of those lobes, because for sure you will get a question on the lobes of the brain. Okay? So the cerebrum, again, is like the CEO of the brain, right? It oversees all the functions, um, and is divided by the line in the middle called the central sulcus, right? If you have your mic on, kindly mute it so that way we have less noise for today's presentation. Now, the frontal lobe is the largest and most developed lobe of the brain, right? It plays the most vital roles in cognition processing. If you think of solving a puzzle, you would need your frontal lobe, right? Creating details about future action or planning, organization would be your frontal lobe, your working memory, planning, prioritizing, sequencing. For example, sequence of sevens would be part of the frontal lobe. Flexibility, personality, judgment, right? Understanding judgment and insight, frontal lobe. Especially personality. Personality has a lot to do with the frontal lobe. Okay. Now, in the frontal lobe, we have a Brocaman's area, which is responsible for expressive speech. When you are able to talk, right? That is the expressive speech. If someone have Broca aphasia, they have damage primarily in the frontal lobe. Now remember that all the lobes are connected, so sometimes a damage in one lobe may also cause damage on the other lobe, but primarily the broken area, expressive speech, is part of the frontal lobe of the brain. The prefrontal cortex, right? Also, communications with complex information would be part of the prefrontal cortex or frontal lobe. Now, remember, we talked about personality being one of the high yield functions of the frontal lobe. Back in the day, there was a story of someone that got injured, right? It's a pretty famous story, and that really talks about the frontal lobe. Someone that got injured with a rough piece of metal passing through the person's brain and affecting the frontal lobe. What is interesting about this case is one, the person survived, especially back in the 1980s, right? Two is that person was well mannered. That person was polite. It was a hardworking male. After this incident, it was a completely a 360. That person becomes um, no longer shy, was talking funny, was expressing things that one should not express in public. So the only thing that he could do after this incident was to get a job in a circus, right? So they really affected his personality. Okay. So personality, as you can see, is affected by the frontal lobe. It has to do with a lot with social skills. So if you have a tumor in the frontal lobe, it would could potentially cause behaviors problems, right? So, for example, a patient with a frontal lobe injury might show changes in speech, reasoning, insight, judgment, and impulse control. Now, impulse control, remember, a lot to do with ADHD as well. So, causing a shift in personality, emotional response, it is part of the frontal lobe, or prefrontal cortex. Right? So, if you think of amnesia, dementia, patients with dementias often exhibit changes in the frontal lobe, leading to personality, emotional states, and intellectual capacity being damaged there, right? Dementia patients, they struggles with maintaining coherent conversations or making sounds judgment due to the frontal lobe impairment. So if one has lack of insight and judgment, right, would be the frontal lobe. Now, if you think about schizophrenia, they have what's the hallmark of schizophrenia in regards to those functions mentioned? What do they do not have usually or have trouble with? Abstract thinking, right? So also part of the lobe that is high yield. Please know that patients with schizophrenia, one of the hallmark is abstract thinking, ability to think in abstract manner. For example, what does it mean if you live in a glass house, you shouldn't throw rocks? Or what does it mean if the grass is not always green on the other side of the fence? We use many mnemonics throughout the course. One that we like to use is Flipper JW for the frontal lobe, meaning F for flexibility, L for language, I for insight, P for planning, P again, prioritizing, E for expressive speech, R for reasoning, J for judgment, and W for the working memory. So aphasia is associated with each part of the. Someone has a hot mic there. Uh, so, okay, sorry about that. Um, Aphasia, and again, depending on which type of aphasia, right, would be the prefrontal cortex. Again, just going over the frontal lobe here and the prefrontal cortex. Now, remember expressive speech, right? How about understanding words? That would be more of the temporal lobe. If it's expressive, is the communication would be the frontal lobe. Understanding would be the temporal lobe. So the temporal lobe, anything that has to do with auditory information in both ears, right? Understanding words would be a temporal lobe. Memory, short-term, long-term memories, episodes, and declarative memory would be a temporal lobe, and emotions would be also a temporal lobe. So when we say things like auditory hallucination, we would think of the temporal lobe. If we say occipital hallucination, then we'll look at, if we say visual hallucination, then we would think of the occipital lobe. But if it's auditory, since understanding words would be the temporal lobe, language, right? Auditory hallucinations would be a temporal lobe. Aphasia, receptive, right? Difficulty in understanding or written language due to a brain damage, temporal lobe. Amnesia. Remember, we talked about memory, right? Whether it's retrograde or anterograde. So problems with forming new memories or recalling past events due to brain injury would be a function of the temporal lobe. We talked about receptive, which is called Wernicke aphasia. It is important, is highlighted, would be a temporal lobe or inability to comprehend both spoken and written language when the speech is clear and present. Okay? Again, lots of memorization here, but nothing too complicated, right? But you could easily see three questions on the lobes itself. So it's important that you fully are able to speak about it, able to recall this information. If we looked at the occipital, the back of the brain, right? The occipital lobe, we would be looking more into a visual functions, right? Primary visual cortex, the hub of vision and processing. Receptive and analysis of the visual information is through the occipital lobe. The visual field defects, right? If you think about the cranial nerves, 2, 3, even 4, 6, lots of the occipital lobe is involved, right? If someone has a partial field vision defect, given that the eyes is working properly, then there would be the occipital lobe that's affected if the eyes are normal, right? Blindness is a great example. If the eyes itself are normal, then there will be because of the occipital lobe. Okay, visual hallucination. Again, occipital lobe. Now, go back here for a second. If we say visual hallucinations, right? Remember dimension. Lots of them may. Which type of dimension is the hallmark of visual hallucination, right? Anytime you hear visual hallucination in dimension, think of Lewy body. Lots of dimension questions on your test. But Lewy body is an interesting one because anytime you hear questions with hallucination, it's very applicable that you'd prescribe a antipsychotics with the exception of Lewy body. For example, if you have a question with anger management, someone with bipolar, but also have visual hallucination. Because of visual hallucination, not Lewy body referring to Lewy body, but in general, let's say you have a bipolar in manic stage with hallucination. Your first action here would not be to prescribe lithium, would be to prescribe a antipsychotic. Now, the exception is Lewy body, because Lewy body, the hallmark of Lewy body is visual hallucination, and you do not prescribe antipsychotics for Lewy body because it would make it worse. Then what can you prescribe? Well, the hallmark of Lewy body is having this visual hallucination. So you would prescribe in this case medications there are for dementia, and we'll cover those medications later on throughout the course. Okay. So, but just remember that Lewy body, even though they do have hallucinations, visual hallucinations, um, do not prescribe antipsychotics. So tips to remember the occipital lobe. Oh, I see. So imagine I like to do lots of a mnemonic and also make funny jokes that I wouldn't talk about on the camera, right? The reason is that the funnier you can make your own acronym, the easier it is for you to recall, right? So when making an acronym, you could do things that are sometimes even inappropriate as long as you're not sharing this to others. But whatever that might be that helps you recall the information, it's helpful, right? So again, primary focus is visual shapes, colors, emotions, integration, visual interpretation. If there is a damage in the vision, think of occipital lobe. Now, the last lobe to talk about today is the parietal lobe. Think of a parietal as all your senses, right? So it's responsible for processing sensory information from the body. Example, the feeling of warmth or of a cup of coffee, right? By the way, I am today located in Asia, Korea, actually South Korea. It is 5 o'clock in the morning when we started today's event, and that's why I'm drinking a cup of coffee. The sensation of the coffee, the warmth of the coffee, it is part of the parietal lobe. Okay, I know. And someone said, wow, yeah, I wake up early, usually about 4 o'clock in the morning. Now, taste, reading, and writing. or example of the parietal lobe. If someone is not able to write, meaning writing a clock, when we do a clock test, clock drawing test, for example, in the mini cog or in the MMSE, which we'll cover later, it is a damage in the parietal lobe that is super high yield for your test. Someone that's not able to draw a clock, it is a damage in the parietal lobe, usually the right hemisphere or the right parietal lobe, also called right hemisphere for the test purpose, right? So involvement in processing taste sensations, right? Cognitive processes related to reading and writing. Remember, sensory information, right? Um, sensory perceptions, right? So when the brain, the parietal lobe is not working properly, they may have difficulty in expressing or interpreting sensations correctly, right? They may mistake. So if someone has tactile hallucination, then it will be parietal lobe, right? How about agnosia, right? It refers to the inability to recognize or interpret sensory information such as a visual or auditory stimuli, even though the sensories itself it's intact, right? So stereognosis is the abnormality in the parietal lobe, right? So difficulty in identifying objects without seeing. By the way, anything that is related to psychiatry and that you have seen in your BSN degree, your initial nursing degree, and you have seen again, at least if it's slightly talked about on your master's or doctor's degree, I can almost guarantee you that you will see on your test. So stereognosis, we've seen this before, like probably my first year of nursing school, right? Advanced assessment. We, I imagine that all of us went through this. Someone putting the key on your hand and asking you to close your eyes. And if you are able to identify that as a key without seeing the object, right, then this would be a stereognosis test. And there would be the parietal lobe, right, function. Very important. So if you talk about the parietal lobe, remember about tasting, reading, and writing at minimum. And the ability to recognize objects without seeing here falls under the parietal lobe, more specifically a stereognosis, right? So again, here, if you want a visual cue of the parietal lobe, think of sensories integration. And some important part of the parietal, uh, more like writing and reading is high yield and the clock drawing test. Okay. Clock drawing test, it is something that you would see very, very often on your test. Specifically, which function, which lobe of the brain would that be included? You also see questions like which psychiatric test would be the mini cog related to, the clock drawing test will be related to mini cog and MMSE. Okay. If someone has symptoms of memory difficulty, planning, challenges with planning, prioritize, and lack of insight, judgment, personality, right? Impulse control, again, ADHD, and we are going to cover which part of the prefrontal cortex is related to ADHD later, right? You would be thinking of C. Someone said C, Mavis, right? The frontal lobe. Yes, you guys are absolutely right. The frontal lobe. So if you haven't identified yet, we do have a chat. You are able to put your message there as well and share any of your insights, like mnemonics, with the groups as well. So I do provide lots of mnemonics, but it doesn't mean it is the absolutely easiest. It's easy for me. So I count that you guys do share your own mnemonics that may make sense for others as well. Okay. So we're moving on. So we cover the lobes of the brain. Hopefully that's very clear. Remember, this session alone, even though it's super simple and I went through it relatively fast, it is high. You probably would not get less than 3 to 4 questions on this first slide alone. Okay. So a lot of questions that we get is, should we, so amygdala located in a partial in the medulla. So we are going to cover the medulla in a second. Okay. So the medulla, it is the limbic system, and we're going to cover in details the medulla. So I will wait until we get to the medulla, so that way we're not covering things again. Let me look at the message here in case if I missed it. Okay. Oh, I'm sharing 2 screens. So thank you for letting me know. Is that what everybody else is seeing as well? Okay. 1 second, please. Let me share just one. Thank you for letting me know. So when I'm sharing something, if it doesn't look normal, please let me know, because I am looking at a different screen that you guys are looking. I'm looking at my own presentation directly. So hopefully this is better. Thank you for letting me know. And please unmute yourself if you do have a question, because oftentimes I might miss the text box, and that's not to ignore you. Okay, it's just I may miss that. So another point that will most likely be on your tasks that we touch base today, it is the clock drawing test. Okay, so why do we care about the clock drawing test? Well, let's start by saying that the clock drawing test is an easy test for cognition. And when we say cognition, we mean dementia like patients, right? So one with dementia, Alzheimer's, or really any dementia that's advanced, they would have trouble with the clock drawing test, which is part of MMSE and the mini cog. Why do we do it? Well, it's a quick, effective tool for neurological symptoms, often in dementias, Alzheimer's, right? When we say dementia, is the bigger umbrella that covers the first part of it would be Alzheimer's. 75% of the dementias are Alzheimer's dementia, right? So 2 minutes, it's how long it takes to do the clock drawing test, right? Is a performance of impairment in this part of the test is related to the right parietal or in the test, it could be said right lobe or right hemispheres. Please note that it is probably the third time I mentioned about the right parietal, right hemisphere, and the clock drawing test. This is a classic question. Okay, we see this a lot, right? You can remember this by memorizing Dr. Parloham. The DR, the damage to the right. The P is the parietal, PA, the parietal, L lobe for the lobes, or OR, operation rooms, when things are assessed. And the R is the right again for the right once more, to, just to really emphasize, because it could be the answer right parietal A and B left parietal, right? So
Question.
yes, go ahead, please.
Will they ever give you as an answer the right parietal or the right hemisphere and you have to pick between them both? No.
No,
Okay.
no, they
Thank
should.
you.
Absolutely. Please ask your questions, okay? Anytime. So just unmute yourself and ask a question. So when you do the clock drawing test, if someone is not able to put it at 11 o'clock in the right position, right, that would be the right parietal, right? So that would be where the damage is grossly located, okay? Again, why? To assess cognitive status. It's an easy test, 1 to 2 minutes. That is high yield as well. Okay. Damage where? Right parietal, right hemisphere, or right side of the brain. And this is a high yield, quick test that we often actually do in practice, right? This is a little bit what a wrong right, the first one, hopefully, and a wrong clock drawing would look like. Sometimes settled, right? Difference. And sometimes more, if you look at the modern visual spatial disorganization, right? Would be the numbers are not in the right place.
Another
Most
quick
severe,
question.
go ahead.
So they'll ask us on the exam about the location and in consideration with the clock drawing test, but will they ask us like moderate, severe, mild? No.
Nope. They wouldn't
Thank
ask you none of that. What they ask is which tests are they located, mini
God.
cog and the MMSC and the part of the brain, and that would be as far as what they most likely ask. Now, there is no guarantee that they will never ask something absurd, but mainly if you focus on the high yield information, the extra, it shouldn't really affect as much. Okay.
Got it. So they're not going to give us like those examples of the clock and be like, if somebody with dementia was doing a mini cog test, which one would be severe?
Yeah, they should never ask you that. No,
Thank you.
absolutely. Great question, though. Okay.
Also,
Yes, go ahead.
yeah, I think also just to clarify a little bit, basically on this test, there's no pictures. Is that what it is?
Yes, there is no pictures. There was some talk about doing hotspots, matching, but that never came about.
Okay.
Or at least I have never seen anyone say, "Hey, I had a hotspot question." Where you're supposed to put the pinpoint where in the brain. But there were some talk about that. I just have never seen that really come through.
Okay. Thank you. Thank you.
So
My-
yeah, absolutely.
Sorry. My rationale behind asking if they would ever ask about the clocks in specific to moderate, severe, etc., is because I know that they will ask you about scales. Scales in correlation to like disease processes and personality disorders. So in my mind, I thought, okay, well, that's also kind of a scale.
It is
So
a
that would,
kind of scale. Yes.
got it.
Yes. Yeah, no, absolutely. So another question that they may ask is why do we use scales in psychiatry, right? And the reason is to assess, being able to assess over time, right? So earlier someone asked about the medulla, right? And I said, wait a second. We'll talk about the medulla when it comes to the limbic system. That is exciting. Okay, so first we covered about the lobe, super high yields. Then we went into the clock drawing test. Now, if we need to understand the limbic system early because there'll be tons of questions on the limbic system. And now let's talk about the limbic system, right? If we say the limbic system, I'm more concerned with 4 parts of the limbic system. Again, this is not a comprehensive review, okay? Because comprehensive reviews are textbook. We cover everything. I know it's a lot that we're covering, but it's not everything. Well, why we don't want to cover everything is because if everything is important, all the herbs are important, then nothing's important. What we are covering on our 30 days PMHNP walk to success is what you need to pass the board. For example, we are not going to talk about the cingulate gyres in the limbic system because it's not important, not specifically for the limbic system. It is important for other things, but not for the limbic system. When we talked about the limbic system, 4 parts of the limbic system is important. The thalamus, it's almost like my name, thalamus. Thalamus, hypothalamus, under the thalamus, amygdala, angry amygdala. You'll see why in a second. And the hippocampus. Okay, so these 4 parts of the limbic system you must memorize early. Okay, so if you think about the not the limbic system, think of it as emotions and memories, right? So why do I care about the hypothalamus, right? Well, let's start with the thalamus, and then we'll go under the hypothalamus. So the thalamus, think of it as a policeman, and he says, okay, you guys are coming this way, you can go. Everyone else on the left side, you got to wait until green light is on. And when the green light is on, everyone from this side, come on, right? So what the thalamus is saying is all your sensory overlay so that the traffic jam doesn't happen is part of the thalamus. The thalamus controls what sensory goes in, what sensory stops here, so that the brain is not overloaded. So think of a sensory relay center. It modulates memories related to behaviors. You could imagine as a sensory switchboard connecting all the sensors but smell. And this but here, smell is super important. We'll cover this in just a second. All sensories, so that your brain is not overloaded at one time, comes from the thalamus. Under the thalamus, we have the hypothalamus, which I like to refer as what the heck, meaning that is the regulations of appetite, thirst, hunger, water, circadian rhythm, right? Your sleep, your body temperature, your libido, and hormones regulation. So the H is for water, or what the heck? I'm sorry. The W is for water, for what the heck, right? Um, H for hunger, A for appetite, T for thirst. H here will be for the hunger, and the E is kind of sex, libido, not really, but if it helps you remember. And the C is for circadian rhythm. Please memorize this because you are often asked what does hypothalamus does. And when this question comes about, I want you to think of what heck, if it helps you. If you do have a better mnemonic, please share. The thalamus, the sensory relay of the brain, so that we don't get all the sensory not smell, touch, visual at the same times, and we don't know what is going on. Now, the hippocampus is another uh, very important part of the limbic system we need to know. It regulates memories. It converts what we learned today and how we are going to remember this in the future. So short-term memories and long-term memories, right? Here is where people get it wrong all the time. Every week we pose this question, and 50% of the students get it wrong. And the reason why they get it wrong is because of the amygdala. If the question says stress, someone's stressed out, it is part of stress regulation. It is part of the hippocampus, not amygdala, right? So if your test has highlighted stress and you are to pick where it belongs, it is the hippocampus, not the amygdala, right? Emotions, learning. Think of it as a hippopotamus, the big head, stressed because it's caged, right? So a stressed hippopotamus, I want you to think of a hippo as a big head for memory, especially converting short-term memory into long-term memory. And he's stressed because he's caged, okay? So when you think of a hippocampus, think of a stressed hippo. Now, where people get it wrong is they confuse with the amygdala, because the amygdala is emotional memories. I like to say that when every time I eat a oatmeal cookie and not eat, smell, not eating, smell the oatmeal cookie. So it brings me memory from my grandma. She's baking, lovely lady, oatmeals, right? That brings me back in time. So the memory connected to the smell is part of the amygdala, okay? Now the amygdala modulates mood, emotional memories, fear, anxieties, and aggression. So people often confuse aggression with stress. If the question says stress, pick hippocampus. If the question says aggression, anxiety, and fear, especially fear and aggression, amygdala is the answer. If the question asks which part of the hippocampus is related to sensory of smell, then amygdala. All other sensories hypothalamus. Thalamus, not hypothalamus, okay? So I like to think as amygdala, emo for emotional, and amygdala as a emotions, and smells, right? Regulates mood and smell, aggressions, anxiety, um, fear, right? So think of it as the amygdala. High yield, okay? We spent a little bit of time. Hypothalamus, what the heck? What the heck is something easy to remember, right? All the sensory of the hypothalamus, what the heck? The thalamus, the sensory board, so you don't get overloaded with sensories. Hippocampus, hippopotamus, he's gelled. It's a big head, short-term memory to long-term memory, and he's stressed. Amygdala, angry amygdala, right? And that controls the smells portion of the sensory. High yield. Okay, and do not confuse the hippocampus with the amygdala. We talked about the stress for the hippocampus, and the amygdala is the anxiety, the aggression. It's not stressed. Okay, very high yield. Go ahead, please ask your question if you do have one. I cannot see the screen.
I had a question regarding will they ask what particular area of the brain those hippocampus, amygdala, and
No,
thalamus, hypothalamus is in?
no, definitely
No,
not.
okay. Because I was just wondering, was the amygdala located in the parietal lobe?
Yeah, no, not
Oh,
important for the
okay.
test. So what they care more is either this is very much memorization. The function of a smell, would that what part would that be mostly like concerned with? In this case, the amygdala, things like that. That's more like basic memorization. They wouldn't go in more detail than that most of the time. Okay. All right. Thank you for your question, though. There was somebody else that
Thomas?
had the question.
Yeah, Dr. Lopez. I just had, it wasn't a question, but it might be helpful for others, like you had said about other mnemonics, but things I think of the hippocampus, think of a campus, like a college campus. So we're converting the short-term information to long-term memory because that's what we want as students. And stress management. We already stress at school. So the hippocampus, sometimes I just find that might be helpful as well if people are thinking of that too. Just throwing that out there.
Absolutely. No, absolutely. Please share, right? So one way to share that's beneficial is in the forum portion of the course, right? Because we can go back there anytime. It's not a lot of people putting a whole lot of information. We can go back to the forum and get those mnemonics that's more helpful, right? The what the 1 second, Louis, please. The WhatsApp portion of the group is quick, right? So we just put like what's in my memory today, what is going on today, and then we just put something in the WhatsApp. But if you try to go back, sometimes it's difficult because we put tons of message there, right? Louis, please go ahead and ask your question.
Yeah, it's not something that may be helpful also. And I love the fact that she mentioned campus. I was thinking about it. For amygdala, the way I remember it, like you can say Amy, like you call it Amy. Amy gets angry because she smells. And that's the only one, like you mentioned, that's the only one that has smell. So Amy,
That's it.
when Amy come to people, talk to people, they always smell. She's there with smell. Because she smells, she get angry. Because she smells, she get aggressive and emotional. All those make me remember the same time. Amy gets angry because she smells. Okay.
There you go. That helps. And guys, I promise you, it seems very simple right now, right? Very easy. But if you don't write down this information, which is the right Parietal, writing down, you might forget. So write down those mnemonics, right? So here it talks about the functions of the medulla. You can think of ME, you can think of emotion, right? Aggression. Question says aggression, it's not the hippocampus, it's the medulla. If stress, hippocampus, right? All right. So which brain structure assigns emotional significance to stimuli? It creates emotional memories. Frequent plays a role in fear and anger, right? So if you just look at the beginning, right, significance to stimuli creates emotional memory. So emotional memories, we don't know where this question is going. If we just look at the stimuli, and we still don't know where this question is going, but the question gives away when it says play a role in fear. If you are in my psychopharm class, I cover fear in details because the fear is a lot to do with anxiety, right? And that's because of the medulla and anger, amygdala, right? So everyone got it right. Again, going super slow because everything is important here in this course, right? I know some of you guys were like, whoa, this is not everything, right? You don't want everything, promise you. If you want everything, this would not be a good course, because if you want if you want a big company like Gerald's or Barkley, they'll give you everything. They'll give you a thick book, but that's not high yield for your test, right? They want to cover everything. Well, I told you it's here in the book. Well, sure, right? But what you want to know is really what portion of the test you want to focus on. So the limbic system is connected to our response to stress. Which part of the limbic system? Again, hopefully that's not a thalamus, right? That was probably a mistake. Okay, all right. So the cerebellum. Okay, let's talk about the cerebellum, because oftentimes we'll see a question about the cerebellum, right? Which has nothing to do with stress, unless if you got pulled over by a cop and you've been drinking, right? The cerebellum is about the balance, right? So please know that cerebellum is balance. What test do we
Well,
do?
it almost say balance in there too. BEL. That might help.
Oh, that might help for
Cerebellum.
sure. What is the test name that we do when we say stand up, put your arms forward, close your eyes, and we assess it?
Romberg test.
Romberg test.
Romberg.
Remember that. And remember that is connected to the cerebellum. Okay? So now the hippocampus is the stress, right? The thalamus, the sensory relay, and the hypothalamus, what the heck? Okay? So here we have it, learning, memories, right? So one time I had a neurobiology test and I thought I knew everything. I thought I was super good, right? I was 3 in the morning, still studying, and the test is 7 o'clock. I went to a school that is not open to the public. It's a closed school and it's only by invitation. And I like to kind of go back to this because it still brings me PTSD to this moment. We had anatomy with cadavers, with medical students, right? And the cadavers that have been dead for over 2 years and have been picked on for forever, right? We had a morgue that we'll go into, and there would be like 40 bodies there, and it would be open 24 hours. And I was studying for this neuroanatomy. And during this class, Monday, we would have 3 tests, anatomy tests. One would be a written portion. 2 would be a visual portion. and 3 would be an oral portion of the test. So it would be all day testing on anatomy, all day, from 8 o'clock in the morning to 5 p.m., right? So I was studying for this test, and then I was like, okay, I got everything good. It was 3 in the morning. And then I went to sleep and then had to get up at 6 and go, no, get up at 7 to arrive at 8. And during the test, I couldn't remember much. It's because you convert your short-term memory to the long-term memory through sleep, right? You have to sleep. And this is so important. Oftentimes we see people, with students studying like that. And this is a wrong way to study, especially before the test, right? So as you prepare for the 30 days, during this time, 30 days, 60 days, 90 days, how long it's good for you, we're here, please make sure that on the last minute, we're not trying to go over every single thing, right? When you've done this course, you are way more prepared than 95% of the other students. I promise you that, okay? So take the time. Someone mentioned train like you fight 2 days ago, yesterday on Facebook, right? So right now is the training portion. The training is a lot harder than the test if you do the training right. Okay. Okay. Here again, we'll cover about the hippocampus. Now let's just put everything together. I'm sorry. I know we just cover everything, but frontal lobe, decision making. Temporal, if you touch on the side of your brain, there's your memory, your hearing, your language. Remember, Rieneker's understanding words, temporal. Frontal, or the broken area, expressive speech, frontal. Hypothalamus, what the heck? Brain stem, we didn't talk about, but think of anything you need to live: breathing, swallowing, heart rate, heart blood pressure. Cerebellum, the drunk guy that needs to be walking straight if you get pulled over. The thalamus, the sensories all over, but smell. Occipital, back of your head, your vision. And the basal ganglion, that will cover a lot of that when we talk about antipsychotics, right? Because basal ganglion, it's all about motion, movements, right? So that is a little bit of a synapse of what we cover thus far. So I like to take breaks, and the reason I like to take breaks is for you, okay? Because I can easily go through 23 high yield topics in 3 hours. But if that's not helpful to you, right? What matters is not how fast we go through the content, but how much you assimilate and you are able to convert your short-term memory into long-term memory. So that being said, let's take a 5 minutes break. I'll see you guys back at 6:10 p.m. Eastern Standard Time. Please get up and walk. So that way we come back and we'll be ready to go. See you guys in 5 minutes. Okay, bye-bye.
6:15. It's now 6:10.
Perfect. Thank you for that. I want you Oh, I'm sorry. I was talking about, and then my mic was muted. So sorry. So I was showing you where the PDF was located under the course, under the first module of each course. I apologize. My apologies here. I was muted. So the PDF is located under the first video of each course. Hopefully you saw the image there, and I don't have to go back to it. That way, what you need to do is download not only the PDF, I would say download the PDF, but I also provide you the purple book there for you. Okay, if you don't have it and you like to have in digital format, you have it. So if you download the PDF, you'd find the everything that we're covering today. Now, I like to say that once we finish on module 1, you do question banks module 1. Now you proceed to module 2, you do the same thing. Finish module 2, do question banks number 2. Now you see that the topics are getting larger, larger, and larger. And when you download your PDFs, what you should do, or at least what I would do, is take that with me to work. So that way, every time I have 10 minutes, I can go through the entire module 1 in 20 minutes by reading each sessions. As you go through each session, especially the second time or third time, now you'd not be looking at the content. You should be able to put your finger on the frontal lobe and say what it does, or say the cerebrum, what does it do, what a part of the lobes are involved, and what each part of the lobe does, right? So that way you're recalling the information, and then you look it down. Oh yeah, I forgot about frontal lobe or prefrontal cortex personality. And then you kind of able to recall that information. Okay, so now we'll get started on module 4 of the training number 4 of module 1, which is the cranial nerve. Remember, anything that you can recollect from your nursing school and you've seen in this course is likely to show up again. Now, this is a lot to memorize, and I'm not going to go through each one of the cranial nerves, right? But you can easily go online and find out more details. We'll go through this super fast, okay? If we think of olfactory, think of smell, right? Be able to smell the cup of coffee. That will be the olfactory, or nerve number 1. There is this mnemonic that I use here. There are others, many others out there. Old Olympus towering top, a Finn and German guarded
See your screen, doctor.
Hi, Dr. Lopez, are you sharing your screen? Because we don't see it.
I am. I should have been, but I took my screen out. Yes, thank you for that. Appreciate it. So if you think of the mnemonics, please share. There are many others. Some are very inappropriate, so we'll not be sharing here. But whatever helps you remember for the test, okay? If we look at the olfactory, think of smell, right? Cranial nerves 2 is vision. Remember picturing an old observant wall where the knee vision, if that helps. Optic nerve 2. 3 usually goes with 2, right? Which is the eye movement. Pupils constrictions, right? Eye movement. Cranial nerve number 3. 4, it also has to do with the eyes, but now it's more of a superior obliquum or the eye movement, right? Cranial nerves number 4. Number 5 is high yield, super high yield. Your facial sensation, your muscles of mastication would be cranial nerve number 5, right? 6 also has to do with the eye movement. Oftentimes I say 2, 3, 4, and 6, even though it's not technically correct, but it helps me remember eye movements. It has to do with the eye, right? So remember, 4 was superior muscle, able to look up and down. Now, if you look at number 6, would be the lateral movement, left and right of the eyeball, right? 7, high yield, is your facial, right? Facial muscles. Taste, there is a portion of the tongue, and not completely 7, but a portion of that is taste, tears, and saliva. Think of this as the muscles of the face, right? 8, it's all about your balance and hearing. 8, the vestibulococcus nerves. 9, high yield, and it is swallowing, taste, also saliva, right? 10 is your vagus nerve, right? Your autonomic function, able to swallow and speak, able to breathe, is vagus nerves as well, right? Then we have 11 is your shoulders, your accessory muscles, your shoulders, your neck movement, and 12 is your tongue movement. Now, if you like, oh, I just want to memorize feels, which one would I do it, right? I would say that for sure you need to memorize. Well, I would memorize all of them, really, but you can put together 2, 3, 4, and 6 as part of a vision and eye movement. 5 is your facial nerve, facial sensations, not nerve, right? 7, so 6, 7 would be your facial nerves, the muscles of the face. 8, not that important, as long as you remember of hearing and balance. 9, super important, swallowing, right? Taste as well. Remember, taste is not only 9, right? Vagus nerves, you need that for breathing and swallowing as well. I mean, breathing and autonomic functions. 11, neck movement, super high yield, and 12, okay, the tongue movement. So please take the time to memorize your cranial nerves. Someone asked, can you explain the face and the numbers? Is one way of remembering of the cranial nerves. But again, this is a lot of memorization, and you should do this one basically on your own, but as long as you remember them, because there will be a question on cranial nerves. Now, it will be a simple question, right? They're not going to ask you in detail about the cranial nerve, but knowing those that we covered today will probably help you with at least one question. I wouldn't say that would be more than one question either, okay? Now, what is the one topic that everybody talks about, right? It's the dopamine pathway. And it's very simple, actually, unless if this is today is the first time you're going through the dopamine pathway. Now, what you need to know right away about the dopamine pathway and about any question that it is, or any topic that is easy, that will make it a hard question. So two topics comes to mind right away, which is the TSH, thyroid functions, whether it's hypo or hyperthyroid, and the dopamine pathways. So on those two topics, the questions will be long and the answers will be long. So what you need to remember for all questions and answers is that if the entire sentence is not correct, then the answer it is incorrect. What do I mean? Well, when it comes to the dopamine pathway, often they'll put a correct answer in the beginning, followed by a incorrect statement. So for those two topics, the dopamine pathway, the TSH values of thyroid, make sure you are really reading all the options and make sure you are asking yourself, is all the answer, meaning the first sentence plus the second sentence, correct? And make sure you are writing that down with an X, a plus sign, or a interrogation mark for each one of those, so that you can really look at those answers and be able to get that point. Okay, if that topic comes out, which I guarantee you that will.
I have a question.
Now,
Sorry.
yes, go ahead, please.
For the exam, do they give you paper and pen that you can have like a blank sheet to like now like write on?
Yes, they do. They give you a sharpener and a laminated piece of paper. So since you mentioned, I did a video on YouTube that talks about the dumping sheet. Everyone should have a dumping sheet. So the dumping sheet is, you get 18 minutes by the time you sit down for the test and the start of your test. So during that 18 minutes, I like to center myself. I am a somewhat religious person, so I like to pray, and I like to focus and knowing that I have done everything that I could and there is nothing to worry about at this moment, right? So that only takes me 2 minutes. So now I'm feeling super good. I am into it. I'm like, yes, let's get this done. And then now I have still 17 minutes. Then what I do is I write down my mnemonics, right? Because it's a lot easier to look at Flipper and be like, oh yeah, the frontal lobe, and then I can just boom, boom, boom. That will be super helpful, because one thing is doing 10 questions, another thing is doing 175 questions, right? So writing down your dumping sheet in the beginning. That's one way of doing it. Some of you guys may want to read everything about the test. This is a standardized test, nothing complicated about it. If you like to take your 18 minutes to read about the test, by all means. Now, this is not what I did and not what I suggest. I suggest you focus, take a deep breath, knowing that the work that you have done has been the right work, knowing that that is outside your control. So don't worry about it. At this point, have fun. So first question that you will get for sure about the dopamine pathways, not really, but related to the topic. Typical versus atypical antipsychotics. When we say first generation antipsychotics, that is the typical. Atypical, it is atypical because it brings something that didn't have for the first generation, and that is the second generation. So what is that something? It is the 5-HT2A, right, which is your serotonin antagonism. So because of that, because it's bringing something, it has to be beneficial, right? Well, yes, but nothing comes without a cost. What's beneficial is, without complicating too much, first generation, it covers 80% of the blockade in dopamine. You don't need to know this, but I'm giving you a overall sense so you remember. 80% of the dopamine. So because it really postulates that schizophrenia or psychosis is an increase of dopamine, so it blockades the dopamine really well, so you don't have psychosis. Okay, because it blockades 80% of the dopamine receptors, it works really well. But it comes with a consequence, which is EPS, movement disorders. But it works really well. The second generation, atypicals, it adds the serotonin. So the serotonin and the dopamine will counterbalance. So now for the second generation, only 60% of the dopamine blockade will be there. 60% compared to 80% for the first generation. So therefore, less of EPS symptoms, but it comes with a little extra, which is a metabolic syndrome, which has to do with the serotonin, meaning getting fat. Okay, I mean, how else can I put it, right? So remember, what's difference? The difference, first and second generation, is that the second generation comes with the 5-HT2A receptors, which is a serotonergic. What is the difference? It comes with less EPS, but more metabolic syndromes. And we'll cover metabolic syndromes in detail. Okay? Now, what is important for you after you pass the test is remember that if you haven't used, you should be using second generation with 5-HT2A, serotonergic blockade. But if it doesn't work and you have tried several medications, you can switch to the first generation, which is more potent, and they should take care of the psychosis. However, being a watch out for EPS, movement disorders, possibly later on. So why should you do it then? Well, which one is worse, having psychosis every day or EPS movements later on? Possibly. Not everyone will have it. Okay? But understanding that you have many tools in your toolbox and why you should do it is important. So now let's back to what matters, the dopamine pathway. Remember when I said that dopamine pathway, 4 pathways. The first one is the mesolimbic. And I said that postulated that dopaminergic surge is responsible for the psychosis. So hyperactivity of the dopamine, the mesolimbic pathway, postulate psychotic symptoms, is responsible for psychosis. Now, remember that when we have a D2 receptors in this mesolimbic pathway, it treats hallucinations and delusion. So if the question is about the dopamine pathway, do not answer the question about acetylcholine. Do not answer question about serotonin. Do not answer question about prolactin. The question, if it's about dopamine pathway, is asking what the dopamine pathway is related to the dopaminergic. So here, mesolimbic, because of excessive dopamine, you have symptoms of psychosis. Now, when it comes to the mesocortical pathway, Here is postulated that less dopamine is responsible for the negative depression symptoms of schizophrenia. Remember the flat affect, the lack of emotion, the sadness of the eyes. In the mesocortical is postulated because of a decrease in dopamine, right? Lack of a motivation, a association, emotions withdrawals in patients with schizophrenia is postulated because now in the mesocortical pathway there is less dopamine, therefore you get more depression-like symptoms. When it comes to the nigrostriatal, the basal ganglia that we covered earlier, we said it's all about the movement, right? So the nigrostriatal pathway, which is our third pathway, is about movement, right? So the dopamine blockade can lead to an increase in acetylcholine. So here you have a fight. You have a fight between acetylcholine and dopamine, and they counteract each other. Because when you have a blockade of dopamine, meaning when you have less of a dopamine available, you have more of acetylcholine, you have a problem. When you have a blockade of dopamine in this pathway, it can lead to EPS symptoms, extramural perimeral symptoms, EPS, such as dystonia, parkinsonia, akathisia, for example, TD, for example. So when I say the blockade here, I mean the pathways, the receptors are blockaded, right? Meaning less of dopamine can go in the receptor, meaning acetylcholine is increasing and less of dopamine in the receptor, right? So the long-term D2 blockades can cause tardive dyskinesia, Parkinsonian-like movements, involuntary facial movements that you see often with patients with TD. Okay, so nigrostriatal, little dopamine, a lot of acetylcholine, you have EPS problems. Okay, which action is serotonin in this pathway? So great question. So in this pathway, because you have less of a blockade of dopamine, because of 5-HT2A, also counterbalancing each other. So you have more of a dopamine related in this pathway, meaning now you have less of acetylcholine and you have less of EPS symptoms in this pathway. So it's not so much that the 5-HT2As, right, second generation comes with dopamine. In this pathway, the problem is not so much serotonin, but it's the blockade, how much of it you will blockade. First generation blockade 80%. Second generation, because of 5-HT2A, you blockade 60%. So therefore, you have less, you have more of dopamine and less of EPS problems. Hopefully that answers your question a little bit. But for the test, you are concerned with the dopamine and acetylcholine. When one is high, the other one is low. Okay? And this is the reason why you have less of EPS symptoms on the second generation, because instead of a blockade 80%, now you blockade 60%. Because you blockade 60%, you have more of a dopamine available. And because you have more of a dopamine available, you have less of acetylcholine. So this is a simplified answer, right? We could go this in very excruciating detail, but neither would be helpful. It would be super boring as well, okay? Now, the fourth pathway is we mentioned the nigrostriatal pathway. The fourth pathway, now we talked about the tubular-fundibular pathway. When we say the tubular-fundibular pathway, then we have to look which dopamines are involved here. right? Which dopamines are involved here. So here, the problem is dopamine and prolactin, right? So when you have little dopamine, you have more prolactin. And when that happens, you have symptoms like amenorrhea, galactorrhea, sexual dysfunction, gynecomastia, osteoporosis, osteoporosis, osteoporosis. 3 times. Very high yield. It's also high yield. What you do or you don't do, patients-wise, that get osteoporosis. We'll cover that in a second, okay? But I want you to remember that the problem in the tubulofundibular pathway is because of dopamine blockade. Here, you have less of dopamine and more of prolactin. Okay, so when you have more of a prolactin, you have high prolactin levels. It will lead to amenorrhea, galactorrhea, sexual dysfunction, gynecomastia, and osteoporosis. I would highlight osteoporosis to excruciating detail. Okay, a patient on antipsychotics medication exhibiting decreased libido, irregular menstruation, it could be because of the prolactin is too high or dopamine receptors are blockading, less of dopamine is available, prolactin is increased, then you have those symptoms that we mentioned. Okay, you can think of Mary Man never travels for mesolimbic, mesocortical, nigrostriatal, and the tubular fundibular pathways. So you should absolutely remember those pathways. You should absolutely remember first generation, typical, second generation, atypical. Atypical comes with 5H2A. Is there anything else? Yes. We don't need to cover for the course, but there is a partial 5H1A. There is other receptors, but mainly for the course, for the task, think of adding dopamine antagonistic, and that is the bulk of second generation. That is different that you need to know. Not only you need to know typical versus untypical, you also need to know that sometimes they refer to those as dopaminergic antagonistic medication. So if your question comes with a D2 antagonistic, that they are referring to antipsychotics. That is important. I have seen actually in my test a long time ago. I was like, oh, they're using a different terminology here. Okay, so they call D2 blockades or D2 blockers or D2 antagonistic. I don't remember, many years, but I remember that was interesting how they switched the terminology. Okay, so again, which dopamine pathway is mostly affected in Parkinson's disease? That would be C, the nigrostriatal pathway, right? Because Parkinson's disease, here I'm referring to Parkinson's disease in reference to Parkinsonia when someone is taking antipsychotics, okay? Not necessarily Parkinson's disease. So in the nigrostriatal pathway, you have a degeneration of dopaminergic neurons in the nigral pathway, which leads to the substance nigra, which plays a key role in motor control, right? So again, if you want to look at it a different way, the mesolimbic associated with the dopamine is triggered whenever the body experiences pleasures, stimuli like sex, food, and anything that feels good, right? So it's all about the dopamine, the reward. Mesolimbic, too much of dopamine equals to, not blockade, but too much of dopamine itself is postulated to cause psychosis. The mesocortical, too little of dopamine is postulated to cause depression-like symptom. Oh, here even mentioned that nigrostriatal pathway is used in motor planning. 80% of the dopamine in the brain is used in this pathway. Okay. Tubulofundibular, remember, dopamine and prolactin, the balance. Nigrostriatal, prolactin, and acetylcholine. Okay. Any questions about the dopamine pathway? Because this is an important topic, and oftentimes people get confused between the blockade is one thing. Blockade, we meaning when we give antipsychotics. The other thing is when we don't have antipsychotics on board. Okay? Any questions about the dopamine pathway at all? Anyone has a different way of explaining this pathway that would like to share? Okay? If not, we'll keep on moving. Very important. Please do not miss easy points. You could easily get 3-4 questions out of this slide alone that we covered today. Okay? And you should be able to explain it easily. You should be able to write it down the 4 pathways and say what is happening here, who is fighting against who, and have a logic behind. And remember, the question is about dopamine, so do not answer the question with acetylcholine. Do not answer the question with prolactin or serotonin. Now, because you have the blockade of dopamine, less of dopamine is available, it could lead to extrapyramidal side effects, or EPS, which are Parkinsonian-like, acute dystonia, TD, akathisia. So Parkinsonism in relation to the dopamine pathway, you know, the shuffling gait, the rigidity, right? They're trying to move, but they can't really move. Pure rolling motions of the hand, like, you know. Akathisia is like anxiety in a sense, is restless, standing still, pacing, right? Acute dystonia, we are going to cover this. This is one of the best ones because you can treat this right away. Facial grimace, right? And TD is a long-term consequence for some people of antipsychotics use, right? Usually after 2 years, 5 years. Book says 1 year you could get TD. Very, very rarely. Now, one that has developed dystonia early, one that has developed akathisia early in the treatment, this is important, they are at risk of getting Parkinsonian and TD later on. Okay? If you give antipsychotic and right away they develop acute dystonia, or within a week or 2, 3, it should be a warning that that patient is very sensitive to the D2 blockade, and therefore they could be at risk for later on developing those conditions like TD, Parkinsonia. Okay. Now we talked about acute dystonia, and I said that's one of the best ones that I like to treat because it's very treatable. Okay. Oftentimes you get called in the ER if you're on shift or on call, and someone comes and they can't really talk. The neck is twisted. They look like they're having spasm of the face, right? Very painful. Facial grimace. You can't understand what they're saying, right? And it's often a sudden development, right? It happens from nowhere. It can be mistaken for agitation or unusual stereotypic movement, right? Now, one type of this acute dystonia is called oculogyric crisis. So in that case, the eye would be looking up and the face would be all grimace, right? And it is a crisis. Really, it is an ER intervention right away, which can lead to the permanent damage by the involuntary upward movement deviation of the eyeball bilaterally. Okay? So what are you going to do for the test is give cogentin. What you going to do or suggest you do for real life, 25 milligrams of Benadryl IV, followed by 25 milligrams 10 minutes later. And now it's like magic. Boom. The patient can talk again. You can ask what happened. And they're like, I don't know. My doctor just increased my medication or started me on this medication and I couldn't talk. Like magic, they'll become normal again. If you think about it, it is a movement disorder. If you think about it, it is because of acetylcholine and acetylcholine and dopamine. So you give a anticholinergic medication, which brings the acetylcholine down. Now more dopamine is available, and boom, you have the magic. So if you understand what caused, it was a D2 blockade that was too much. What you need to reverse is decreasing acetylcholine by giving an anticholinergic. I'm giving you not only the medication, but the rationale so you can fully understand what caused it and how you are going to reverse according to the knowledge that you understand now. Okay, so you give an anticholinergic, which can be cogentin, benzotropine, which is cogentin, or Benadryl, anticholinergic medication. Okay, so acute dystonia, right? Here is a little of what we already covered. Just take a quick minute to read it. Remember the crisis. Remember oculogyric crisis. I rolled up in the back position. Look at this little kid. It looks painful, right? What are you going to do? Cogentin. This is a medical emergency. Really, acute dystonia is serious. But if we talked about this specific oculogyric crisis, it's high yield for your board. Okay, so akathisia, right? Restlessness, pacing, walking back and forth, moving the chair excessively. This is more than what you'd see with anxiety, but it looks like excessive anxiety, right? Patient can't stand still, right? And no wonder many people think that this is an anxiety, but it is an akathisia. It is part of EPS symptoms. What you can do is beta blocker. Now, this one specifically, it could be that the test comes with beta blocker and cogentin for akathisia, excessive restlessness. Pick beta blocker. Now, if beta blocker is not one of the answer choice, cogentin would do it. Okay? Please remember beta blocker. So what akathisia looks like? Hey, I can't stand still, right? Restless, agitated. Looks like anxiety, 101 here. Right? Panic, frantic. Right? Remember beta blocker. Now, akinesia, if akathisia is restless all over the place, akinesia is standing still. Difficulty initiating motions. I'm feeling like no motivation whatsoever, right? Now, this one, you do not give a beta blocker. Again, it's all about cogentin. So the first three that we covered today, cogentin could be the answer choice, right? What does it look like? Standing still, right? So mostly commonly associated with Parkinsonian, right? They're trying to move, but they can't. Feeling frozen and stuck, stiff. Okay. Again, cogentin. Now, pseudoparkinsonia. Remember again, the problem here is that it looks like Parkinsonia, true Parkinsonia, muscle rigidity, shuffling gait, can't move much, mask-like facial expression, pure rolling, tremors tremors in the fingers, right? So a patient who appears uninterested due to facial expression might experience pseudo-Parkinsonia. So what are you going to do? Cogentin. So everything you could do cogentin, almost everything. Now, what you cannot do cogentin is TD, often tested. Which medication would you avoid in TD? Is cogentin. Now, someone asked me, can they fake involuntary muscle movement of the mouth or the face or the jaw, right? Or the limbs. No, it's involuntarily. Well, can they fake it? I mean, I guess everyone can pretend to do something, but those can they control it would be the best question. No, they cannot control. It's involuntary, right? So usually happens between 1 and 2 years, right? If occur acutely, is a chronic acutely during acute. It could occur during acute prescription, but is unlikely, right? Usually chronic during the treatment. Now, you reduce the dose of the medication if that happens. You also have medications that are less likely to cause TD. Okay, so on the test, what would be the treatment? Remember, all this is knowledge. What the test cares about is what you are going to do. Your first action would be to decrease the dose of the medication. Other actions that you could also do. Remember, this is an expected, and there's not a adverse side effect. It's more of a side effect than an adverse side effect. Here, you somewhat know that they are likely to get TD if they use it for long term. So what are you going to do? Completely stop the medication? No. You're going to reduce the dose and see if there is a compromise between the symptoms and less TD movement, tardive dyskinesia issues. Now, you could also prescribe two medications, which is called Austedo and Ingrezza, right? What you do not want to do is give Cogentin, high yield. What other non-antipsychotic medication that could cause TD? Let's say you get a call from the ED and patients present with tardive dyskinesia like, and they will give you a list of medication, and one of those medication is Raligan. It is high yield. You need to know that Raligan could cause TD. Now imagine someone taking an antipsychotic and Raligan together. That's a perfect bomb, right? About to explode any moment. Now remember that Raligan could cause TD, and there's high yield, right? You can do a mnemonic drape to remember the extrapyramidal side effect, like dystonians, akathisia. You could give beta blocker or Cogentin, dystonia, Cogentin, akinesia, the lack of movement, Cogentin, Parkinsonian-like movement disorder due to antipsychotic, Cogentin, TD, tardive dyskinesia, no Cogentin, Austedo or Ingrezza, or simply decrease the amount of medications. Okay? Now,
Dr.
real
Lo-
life. Go ahead, please.
I have a question. So
Sure.
in test, if we have the option as far as the treatment goes, and we have changed the medication and we have decreased the medication, which is the best option then?
They shouldn't give you that option because it's really patient specific. It's really now it's getting to a little bit more of a critical thinking. Decreasing the medication would be a great option. Now, what they might ask you is which of the following medication has the least potential for EPS, right? Right away, the first answer would be second generation. Now, if they give you other second generations, you could say that to choose from, Abilify would be a great option. Now, what I wanted to highlight is that Clozaril is one of my go-to medication. Once I have tried the second generation, another second generation, and now I'm having still EPS problems. Clozaril often is one that is highly recommended. But we'll go through that later in the course to see the reasons behind it. But oftentimes the answer is Austedo or Ingrezza, or decrease the medication. They shouldn't give you switch to another medication like Abilify, which is also correct because both answers are correct. It really is patient dependent, providing dependent at the time of the assessment. Does that answer your question there?
Yes, it is. Thanks.
Okay. Deborah, do you have a question? Guys, I cannot see your hand, so please just unmute yourself if you do. Jacqueline, do you have a question? Or Deborah? No? Okay.
I have a question.
Go ahead, please.
So in regards to, you say we can decrease it, but what if it had, I know someone asked in regards to, you know, whether it's to like change the medication or decrease it, which one would you choose? You said decrease is the better option, but what if they now say discontinue or decrease? Like they have a question, could that still be an option that they'll throw in there? Because a lot of times I'm thinking of like, okay, they're having TD, discontinue the medication, but you're just saying decrease it. So would that be better than actually discontinuing it?
It really depends. They must be on a different medication, right? They must be on a antipsychotic. So therefore, decreasing would be a good option. Now, remember, the test is testing the gold standard. Austedo or Ingrezza is more of a new medications in the market. Now, if they give you an option to add Austedo or Ingrezza to the treatment, that is a key point to decrease TD, and that would be the right option, right? So another thing to remember, that's high yield. If you have someone that is stable and now they develop metabolic syndromes, right? So your action is to decrease the medication, or option one, the first option is to add physical exercise to the regimen. It's not to decrease the medication. If you are addressing metabolic syndrome, your action is to add lifestyle modifications to the treatment. Okay, I know it's not necessarily answering your question, but it's something that came to mind because oftentimes that question will be asked. Okay, so now for your question specifically, I think it was Queen, then if the option is given between decrease of medication or adding Austedo or Ingrezza to the treatment, that would be the best option. Second best option would be to decrease the amount of a antipsychotics on board. Third option, switch to another medication would be on options as well. Okay. Deborah, do you have a question there?
Yes, Dr. Lopez, but I think you answered the question. 'Cause I was thinking with acathism that beta blocker the adaptation, but you said it would be like tricky, they won't just like that.
I think I could not hear you very well, but if I already answered the question, then that should be okay.
Are you hearing me better?
Your mic is coming out not as clear.
I was asking with acathism that beta blocker and adaptation.
Okay.
Please use the chat.
Yeah. Okay. Courtney, do you have another question there? Okay. All right. We're moving on then.
Dr. Lopez,
Yes, go ahead.
I just want to ask a pharmaceutical related question. It's kind of an ethical question. So the
Okay.
medication like Reglan, where we know that there's a strong risk or any risk of TD, why would they continue to even prescribe that? I know it's got the black box warning, but then they start looking for other ways to use it. Your pharmaceutical companies, I mean, doesn't that put the general population at risk?
Sure. But here is the point that you need to know for the test. Anytime high yield, you just touched on a high yield topic. Anytime, let's say you're prescribing a medication. This is very important, guys. You prescribe a medication and later a black box warning come out. What do? Your action is only one. Is not to decrease the medication, is not to change the medication. Your action is to look at the research for the positives and negative reasons for continue or discontinue your medication. Now, Reglan, why is Reglan used for? It's not for a is not for antipsychotic purpose, right? So someone may use Reglan because they have GERD, esophageal reflux, right? It can treat conditions like slow emptying of the stomach and intestinal tracts, right? So now it has a black box warning, but just because it has a black box warning is not a reason for not prescribing. If you think about this, what is the black box warning for an SSRI? SSRI, right? Would be an increase in suicidality, but you're prescribing because you want to decrease suicidality. So just because you have a black box warning, high yield point number one, you do not, this is high yield, this will likely be on your board. You do not discontinue the medication. You look at the research and you compare the positives and negative symptoms of why you prescribe it. Okay? And point two is that just because it's a black box warning doesn't mean you should not prescribe it. It's just a warning that you have to discuss with your patient, right? And then evaluate, should you do it or not? Okay?
Thank you so much. I appreciate that. Thank you.
Absolutely. Now, pharmacokinetics, right? Think of it, it's another point you need to know. Pharmacokinetics, the definition of it, right? Pharmacokinetics. You can think of, again, you saw this in nursing school, and again, you saw this on your program. Pharmacokinetics, what the body does to the drug. Now, that's too simple, right? If the question it's about the drug's absorption, if the question is about the drug's distribution or the metabolism or excretion, that is pharmacokinetics, what the body does to the drug. You can think of this as ADAM for absorption. The drug is moving through the body, occurs in a small intestine with oral agent that's bypassed once it's IV, right? Distribution, the amount of the drug that's absorbed depends on the patient's condition, like the type of drugs, the route of the administration affects distribution. Metabolism, how the drug is broken down in preparation for elimination. First pass. What does the first pass means? It means that, let's say a drug has 10 hours. When you have the first pass, after 10 hours, 50% of the drug would be available. When you have another 10 hours, 50% of the 50% available. So usually a drug is about 5 to 6 half-alive. And the half-life varies for each drug. Some might be 2 hours, some might be 10 hours, right? So the metabolism has a lot to do with your cyclochromes P450, right? Which is the enzymes in the liver that affects how the drug is metabolized. And that has a lot to do with your inhibitors and your inducers that we'll be covering in a minute. Please know the definition of pharmacokinetics is the study of what the body does to the drug and what it does: absorption, distribution, metabolism, and excretion. Okay? High yield, you're likely to get a question on pharmacokinetics, the definition. It may not come with what the body does to the drugs. It may come with absorption, distribution, metabolism, and excretion in disguise, because it's too simple to have to say what the body does to a drug. Okay? Now, half-life, we just talked about the half-life concept. Now, remember that metabolism, how the drug is broken down in preparation to elimination. Now comes another high yield topic inside the pharmacokinetics, what the body does to the drug, and that is your inducers and inhibitors. The concept is very simple, but the question is likely what will you do to fix it? So inducers are the medication that speed up the rate. It induces out of the body. It induces the metabolism out, right? So if less of the medication is in the body, then you are at risk of not treating the condition that you prescribed. Not enough of available. So therefore, you are at risks. Your risk here would be not enough medication and you're not treating the condition, right? Hypotherapeutic levels. So what would be your action? Increase the medication. So for example here, very, very classic. You will get this one for sure because it's classic. So if someone, how do we apply? If someone is a smoker, right? So the chemicals in the tobacco, the smoking, the burning, not the chemical in the tobacco, but the burning chemicals, right? When someone is using clozaril or clozapine or olanzapine, high yield, right? There is an inducing of the CYP1A2 high yield. So for two medication, clozapine, olanzapine, the CYP involved is 1A2. Because it's inducing the medication, the smoking, it lowers the body level. On the other hand, if they stopped the smoking, it will increase the amount of medication. So your action, if they are smoking, you prescribe more. If they are currently smoking and they say, hey, I want to stop it, smoking or just stopped, your action is to decrease the medication. So is everybody very, very clear here? You will get a question like that. Sure, go ahead.
I don't know if this is necessarily board related. It's just something I've seen in clinicals is that a lot of my patients stopped smoking and went to vaping.
Yeah, so it's not necessarily the nicotine, and I do not have, it is the burning mechanism, like charcoal, like burning the charcoal would be also have this polycyclic aromatic hydrocarbons, right? So it's the mechanism of the burning, not necessarily of the tobacco, cigarette chemicals in it. So yes, it is a very high yield topic. In some countries, vaping are now prohibited, right? So it's something new that's coming up in the last few years, and now we are seeing the consequences of it. Remember, clozaril, thank you for the question, and the olanzapine, and how it is related to the inducers, less of the medication available in the body. If there is smoking, you need to increase because less is available. If they stop smoking, you need to decrease the medication. Now, there is more mnemonics to remember, but few that you need to know is that St. John Wort is an inducers, epileptics medication like phentonin, right, would be on one, carbamazepine, inducers, super high yield. Well, for clinical, carbamazepine almost decrease any other medication's potency, right? So for example, if you have someone with OCP, right? And they are taking carbamazepine and OCP, then what is your action? So you know that carbamazepine is an inducer. It decreased the medication OCP. Less of it would be available, so therefore they could potentially get pregnant, right? So now let's take a look on how to remember. So here I say, this is one way of doing it. It's not necessarily the right way, but is how I would do it. I would not waste my time memorizing inducers and inhibitors, both. I like this one. And this one I remember every time. Drop, act, scam, GBS. So if my medication is not an inducer, I will assume it is an inhibitor. Now, I said it's not the right way of doing. The right way of doing is memorize both acronyms, right? But who has the brain power to do this, right? So what I do, I put in my dumping sheet, drop, act, GBS, or I even put my dumping sheet, psychface.com. But I would definitely memorize what drop, act, scam, GBS. So the D for Dilantin, R for rivapentine, O for oral contraceptives, right? P for phenobarbital, A for any antivirals. They usually end in AVIRs. Carbamazepine, tobacco smoking, sulfur drugs, clozapurines, alcohol, chronic inducer, methadone, also antivirals, barbiturates, and so on and forth, all inducers. You need to memorize at least this list. Okay, this is a very important list, because if you find a medication X plus any of these, then you know that you need to increase your medication X. Okay. Now, inhibitors, right? If inducers, less of a medication is in a body, inhibitors, more of the medication is in the body. So it slows down the metabolic rate, leading to an increased level of drug. Therefore, you have a risk of high toxicity. So think about this, a substrate. The substrate is the chemical of your drug that you're prescribing. In this case, risperidone. The inhibitor here is paroxetine. So what's going to happen to the substrate? Now, instead of 3 little balls there, right, risperidone, now it's going to be 5. So more of it is available. A lot more than you think. Well, I prescribed 3, now I have 5 in the body. How is that possible? Because the slowdown of the breakdown of the enzymes over time will lead to more of it than what you would expect if the inhibitor was not on board. Okay, does that make sense, everyone? Okay. All right, if someone had a question, please go ahead and ask. I just heard a little sound. Okay.
I didn't have a question. I just wanted to share a way I remembered that smoking was related to the CYP1A2 enzyme.
Yes.
I just think about a cigarette is one cigarette, and it's between 2 fingers that looks like an A.
Okay, that works.
And it's 2 fingers, CYP1A2. That's how I always think about it and remember that, and that it's an inducer.
Yes. So
thank you. I'm so happy.
Yes, good. No, that's one way that a lot of people do remember. If that works for you, great. If it works for others, and a lot of people use like this mnemonics too. So thank you for sharing. So if you are not comfortable with the previous mnemonic and you want to memorize this one instead, that's okay. If you want to memorize both, it's okay. So inhibitors, more of the medication is available, and you can memorize by saying psychface.com, right? And now you have your inhibitors here. a list of inhibitors. So I would definitely put on your dumping sheet sickface.com or the inducers of mnemonic that we just covered. Because that way, if you get on a question and you're like, oh my God, I don't remember about isoniazid. What is this, inhibitor or inducer? Then you can just go back to your list and at least see an eye here and be able to kind of remember this is an inhibitor. Very helpful. And another thing too is that questions often will come up with the patient is stable, plus something happened, something was added on. And immediately students goes to, this is an inhibitor or is an inducer? When the answer is none of them. The answer is whether the medication is in the list of those that cause mania or depression. We'll cover in a little bit more because this is like a very high yield topic because students initially goes, oh, either it's an inhibitor or it's an inducer, and this is why I'm doing X, Y, and Z, when that's not a cause. But the cause is because the medication will either cause mania or depression. And we'll get back to that point, but I just want to put this in the back of your mind. Don't assume right away because it's a very popular topic. Very popular topic that is either inducer or inhibitor. All right. So again, few things to remember. Not super high yield, but just for more of your knowledge, depending of the race, ethnicity, that is some of the medication is metabolized differently, right? I want you to remember few other things like carbamazepine, the 3A4, right? Impacting oral contraceptive. We just saw that carbamazepine was an inducer because you have now carbamazepine on board, the oral contraceptive may be less effective. Inducers cause less serum level of the medication, less available. Inhibitors causes more of the medication available, thus at risk of toxicity. And always remember it. They may not be asking about inducers and inhibitors. They'll be asking what action do you take? But you have to take a step back and understand the inhibitor and inducer, so that way you can answer the question correctly. Oh, sorry, clicked the wrong screen here. All right, so again, moving on. Now, few factors affecting metabolism. This question you're likely to get as well, right? So our bodies are different or act differently depending on our age, exercise, fat amount, and so forth. So younger children, right? They have a rapid metabolism, right? Very rapid. So less of a drug concentration is in the body, while older people have a slower metabolism, so they are at risk for toxicity. Well, then if you get Tylenol, would your dose be less for the younger children? Yes, because we're talking about different, like we're talking about 40 pounds versus 200 pounds. But if we're talking about the metabolism, the breakdown of the medication would be much faster in younger children than it would be in a older adult, for example, right? Obviously, we were doing the medication per pound, or then it would need to be adjusted. Now, elderly, you need to know that they have a decrease in the intracellular water, so dehydrated. They have a decrease in protein binding, meaning less of the protein is binding to the, less of the drug is binding to the protein, so more of it is available outside the binding. They have a lower muscle mass and reduce metabolism. And the only thing that they have increased is increasing fat or body fat. Okay, very important. You need to know specifics about elderly. How is one compared to younger adults or younger children, for example, not younger adults, but children. Okay, so you need to know that they have less of protein binding. So oftentimes tests will be increasing protein binding, right? Because there's a subtle difference here, and ask you about adults, how the drug is metabolized for older adults. Now, if you think about metabolism, think about most of the drugs are metabolized through the liver, right? If you have a liver compromise, then your first pass could take a little bit longer. If you have renal insufficiency, specifically for medication like lithium, you could have an increase in lithium level. So depending on the medication, or the renal or liver injuries could result in a different serum amount. Okay, now let's talk about lithium. Okay? Kidney diseases, specifically NSAID, ibuprofen, and lithium will cause lithium levels to double. Any kidney injury, acute or chronic, could cause lithium levels to elevate. Any medication that's metabolized by the kidney plus lithium, like lisinopril, thiazides, the kidney medication, right? It could cause increase in lithium level. So I said NSAIDs could double the lithium level. Now, another high yield question inside of this point here is, what is ACE inhibitors also used for? Okay, sure, you can say to decrease blood pressure. You are right. But for that purpose, ACE inhibitors also is used for heart failure. I would write down ACE inhibitors equal to heart failure medication. Please don't forget about ibuprofen, NSAIDs, and its relationship to lithium. Now, just because someone has a kidney injury and protein, and they do the stick test, and they will look at amounts of a protein in the urine in this +4. It doesn't mean you need to stop the medication, but it means you need to monitor closely. Okay? It doesn't mean you need to stop, but you need to monitor very close.
I have a quick question.
Go ahead.
So I've seen that before, like +4. So at what point do you have to stop? Or you don't stop at all?
When you have symptoms. Right?
Okay, thank you.
If you have symptoms, but it's a warning that hey, you might get symptoms. Same thing as lithium level 1.3 is above what we want, 0.6, 1.2. We don't stop the medication, but we assess. 1.4, we assess. 1.5, we stop the medication for test purpose. Clinical, well, I have seen 2.0 and provided said, hey, continue prescribe. For the test, we stop at 1.5, 1.2, 1.3, 1.4, we assess. We do not stop. If they have symptoms, we stop. If they don't, continue the medication. Now, low body mass, reduced protein, increased fat storage can lead to drug increased concentration and risk for toxicity. Hey, we mentioned this on older folks, right? So intercellular volume, the amount of water in the cellular, right, can affect the drug concentration, reduce in elderly because they are dehydrated, but increased in pregnancy. When someone is pregnant, they have an increase in the water retention, right? Potentially require a dose adjustment. So now I hope you understand how the body, depending whether it's children or adult, it affects the metabolism of the drug. Please know how older adults and even children is faster, older adults is retaining more of the medication, and the reasons why they're retaining more of the medication. Important. Remember, even though we're covering a lot of topics, that is just 10% of, well, I would say it's 90% of what you need to know, but it's not everything. It still is a lot less than what a whole book would be. Okay? Can someone please read this question kindly and answer? Give me a 5 minutes break.
I will. Good evening. Remember that certain aspects make older adults more prone to drug toxicity. What is the crucial factor to take into account when treating them? A, reduced body fat. B, enhanced liver capacity. C, diminished protein binding. And D, heightened muscle concentration. So I read the question. It's for older adults. We're prone to drug toxicity. So if I had to take two away, I would say enhanced liver capacity and the heightened muscle concentration. I would get rid of those two.
Okay.
Yeah.
So what would you answer?
I would say C, diminished protein binding.
Yeah. So when it's crucial to take into consideration when treating them. Yes, CA is reduced body fat. It is a true statement, right? But is that a true statement? No, right? It is increased in body fat. So I guess the question wasn't really clear, but when you are, what do you really need to know is that, like, they have increased body fat, they have a decreased in liver capacity, and they have less muscle concentration, but they have a decrease in protein binding. That is the crucial part, because if they have the decrease, they have a higher risk for increased toxicity. Okay. Now, test questions, they would be more clear on the asking here. Please, please, please. Not for this one because it's not very clear, but when answering the question, ask yourself what is the core of the question and answer the question before looking. You say, okay, when treating older adults, what would I be concerned with? And then you answer the question without looking, and then you match. Because if you don't, it's likely that you could be getting, the question, the answer, but you're getting tricked by the answer choice. And then one way to do that is by answering the question in your own words. When you answer the question in your own words, then you go back and match it. And this is a practice. Every time you practice, you get better on the test date. But if you change on a test date, it'll be hard for you to get it right. So it's going to take a little while. Okay. So yes, older adults, they have a decrease in protein binding, which means they have an increase in drug concentration, making older adults more susceptible to drug toxicity. Okay. So this is a clear example of the question. Was a bit confusing, but it's a clear example of what we just learned, how we could apply here. Okay. Can someone please read this question? Any volunteers? No?
I'll read it.
Okay, please go ahead, Mavis.
65-year-old woman. A 65-year-old woman has been on 900 milligrams of lithium regimen for bipolar disorder over the past 7 years. Recently, her primary care provider prescribed hydrochlorothiazide 12.5 milligrams daily due to hypertension. She now experiences muscle weakness, ataxia, nausea with a lithium level of 2.0 milliequivalents. Which drug interaction is leadingly responsible for the mentioned symptoms? Is it A, low potassium, low sodium levels, accelerated removal of the lithium by the kidneys, slow removal of lithium by the kidneys, or reduced clearance? I'm going to say it is, I don't know.
Ask yourself, what is the core of the question? What is the question asking you in general, in simple format?
Okay, the question is asking me, she now experiences muscle weakness, ataxia, nausea, with lithium, with a lithium level of 2.0.
Let's do this. So you had someone on lithium that was stable, because it says over the past 7 years. Something else was added. What was added? Hydrochlorothiazide. Now she has lithium toxicity. Then the question, the core of the question is, what drug interaction most likely happened here? So if anytime someone is stable and become or unstable after something else added, it was because of the added medication, right? So what, and then we talked about hydrochlorothiazine ACE inhibitors cause a decrease in lithium toxicity. Yeah. Decrease in lithium clearance. Okay.
Yeah.
So what would be your answer choice?
Decrease in lithium clearance, slow removal.
Exactly. So your answer choice would be D. So here is a clear example of you're likely to have the knowledge, but applying could be a problem, right? So always ask yourself, what is the core of the question? What happened? What caused this person to be unstable? It was the adding of the medication, hydrochlorothiazine. So therefore, because it injures, it causes the lithium the kidney to be increased by the kidney, right? Because more of the water is released because of this medication. So therefore, more of the lithium is staying in the body. So you had to reduce in lithium clearance. Okay. So thank you for that. But yeah, thank you for reading that for sure. All right. So option A, hypokalemia, it doesn't really explain the lithium level. Hyponatremia, while this could be a side effect of hydrochlorothiazide and it leads to some symptom, it doesn't directly account for the lithium increase necessarily. This is more of a reduced lithium by the kidney. Okay. All right. So this is, go ahead, ask your question. If you have a question, please ask. I cannot see your screen. Jacqueline, I believe. Okay. You have to unmute yourself if you're trying to talk. Or anyone else? Jacqueline, we cannot hear you. If you do have a question, you have to unmute yourself. Okay. So, go ahead, Jacqueline. I think you are on.
All right, yeah. That question that you just read, is there a way we could go over that question? Because I'm not understanding the hypokalemia part of it.
So hypokalemia has nothing to do with that. But hyponatremia, one could even say it was because of hyponatremia, which is low sodium.
Right.
But,
So that's what I understood. But I thought the answer at one point when I read it, it says hypokalemia, and I was kind of confused.
No. It was not hypokalemia. It says the incorrect answers why it wouldn't be hypokalemia.
Oh, okay, I get it now.
Yeah.
All right,
But
thanks.
yeah. Yeah. So we'll leave it at that. Courtney, you have a question there? Okay. Let's move on then. If you do have a question, please unmute yourself. So we talked about earlier, right? Pharmacokinetics. Now let's take a look at pharmacodynamics, right? So we talked about pharmacokinetics, pharmacodynamics earlier. Now let's take a look at pharmacodynamics. So if pharmacokinetics is the study what the body does to the drug, now pharmacodynamics is another terminology you need to know. Guys, please do not confuse this terminology because it will be an easy point that you could miss. So pharmacodynamics is what the drug does to us, to the body, right? And this can be very complex, right? It includes how the drug interacts with the receptors, ion channels, and enzymes. That is not important. What is important is the definition. And if it says, now that you know the definition, what the body, what the drug does to us, then we got to think the receptors, ion channels, and enzymes. Okay? For example, an increased neurotransmitter actions in the synaptic cleft can improve neuron communications, because that's how the neurons communicate with each other, right? Or combining SSRIs, NSAID, aspirin, protein may increase the risk for bleeding, right? What the medication does to us. So what is important here? Pharmacodynamics, few concepts. And this one, a lot of people get it wrong. And this one, again, we've seen this in nursing school, I believe, and also definitely seen this on your master's, doctor's degree, right? So pharmacodynamics, the receptors. When we talked about the receptors, we have this spectrum. A for agonistic, all the way to inverse agonistic. And in between that, we have partial agonistic and antagonistic. So what the body does, what the drug does to us. So you need to know this exactly as I am saying here today. Agonistic. It activates a receptor response, a chemical response. It activates a chemical response to produce a biological response. So basically, activates to produce a response. Know exactly this terminology. Activate the receptor by a chemical to produce a biological response. Example, morphine mimics endorphins. So by binding to the opioid receptors and producing the pain relief. So it will activate the receptor, and the biological response will be reduce pain relief. Agonistic, activate the receptor by a chemical to produce a biological response. Now, if we look at this and say, okay, so that is the agonistic. Now, the partial is a beautiful medication because it kind of balances it out. What you don't have it with what you need. So it binds to a receptor, but does not fully activate let's say the receptor goes up to 10. When you have a partial agonist, it goes up to 5. It results in a minute or less potent biological response. Like, for example, buprenorphine. It binds to the opioid receptor, but has a lower efficacy than the full agonistic like morphine, making it helpful manage opioid dependence. Boom! Now you know why buprenorphine, it is a controlled substance, because it actually activates the receptor. But does it activate like heroin, like cocaine? No. So it activates partially. So this why is good for withdrawals of opioids, but it's not going to give the full high. It's just going to slowly prevents the withdrawal, but it doesn't give the full high. Hopefully you understand what I'm trying to say here in a way that you remember for the test. You don't need to know that buprenorphine is a partial agonist, but you need to know that a partial agonist binds to a receptor but does not fully activate it. The buprenorphine example is more of a connecting later in the course and the reasons why behind it. Now, what you need to know by the letter is agonistic, inverse agonistic, by the letters here. So inverse, it binds to the receptor as the agonistic. And what it does is exactly opposed of the agonist response. So it activates, causing the reverse effect of a agonistic. Okay, so a good example here. Let's say what would be an inverse agonistic for benzotropine? That can cause anxiety and convulsions in treating for a relaxation or sedation, for example, right? Inverse agonistic for anxiety. So here, another, what would be the treatment for benzodiazepine, let's say benzos, what would you give if someone has a benzo overdose?
Narcan.
Narcan. So now you would be an inverse agonistic. It does the opposite of the, well, it would actually be more of a blockade of the antagonist. And so that would not be a good example. But understand that the inverse agonistic is a oppose of the agonistic effect. It does the inverse. Now, when you say antagonistic, what it does is sits there. It does nothing. It blocks the receptor to inhibit the biological response. It basically sits there and says no one is going to connect to this receptor. This receptor will be inactive. Prevent a endogenous agonistic from binding or exerting their effect. So that will be more of a example of Narcan. Okay, so naxolan acts as an antagonist at opioid receptor, reversing the opioid overdose by blocking those receptors. So basically, it blocks that and sets that. It says you're not going to activate this receptor, not necessarily completely reversing. Okay.
Dr.
Hi.
Yeah, I thought Narcan is for opioids and not benzos.
Yeah, correct. For
Right.
benzodiazepine.
Yes. So naxolan acts as an opioid antagonistic for the opioids receptor.
Yeah,
Okay.
not for benzodiazepines.
Not for the benzodiazepine. You're absolutely correct. Thank you for that, for sure. I appreciate that for sure. Okay, so guys, the point here that you need to know is agonistic, right? It produces a biological response, and you need to know this exactly as we're saying here, because this is exactly how it might show up in your test. Then you have inverse agonistic, which binds to the receptor as an agonistic, but induce an opioid biological response, opposite of the biological response. And the antagonistic, it binds to the receptors, preventing a endogenous response of the agonistic from binding or exerting their effects. Okay, so now we could go also into pharmacokinetics. We went to the receptors. We can talk about ion channel blockers, like calcium channel blockers, potassium chlorides. That is not super high use for the test. Okay, so I will skip that part. It's more of a pharmacokinetics, more of overall, but not super high use for the test. What you need to remember is this here: pharmacodynamics, right? What the body does to the drugs, what the drug does to your body, I'm sorry. Agonistic, inverse agonistic, and antagonistic. And partial, it will be a partial response. Okay? So the two definitions between pharmacokinetics and pharmacodynamics you need to know. May I have a reader? Anyone that could read this question, please? Okay.
I'll read
So
it.
please, thank you.
You're welcome. What action does an agonist receptor produce? A, partially activates the receptor, resulting in limited activities. B, prevents the agonist from opening the channel and does not trigger a biological response. C, creates an opposing effect to the agonist, causing the receptor to close the ion channels. Or D, initiates a biological response and opens the ion channels. I believe it's D.
All right. So everyone say in the chat box, it is D, right? The correct answer. So thank you for that. It
You're
is
welcome.
D. So yeah. So guys, if we're covering today or any part of the course, you are likely to see on your test. This why, and there's a lot of information. I get it. This why downloading your PDF and taking it with you to anywhere you go, it's beneficial, right? Also, it's beneficial, the Brainscape app, because you can go through the subject very, very quickly on your Brainscape app. I'll talk about the Brainscape app at the end, okay? So that way we can be on track. Now, neurotransmitters, right? So if you say one thing for each of neurotransmitter, this is just for play. If you want to say one thing, I would say acetylcholine has a lot to do with movement and memory. Dopamine is all about the pleasure, right? That's why this is why a lot of people seek drugs, right? Because of the dope and GABA, right? They seek the pleasure. Two receptors associated with SADC, dopamine and GABA. High yield. Write that down. Amphetamines or adrenaline, it's about fight or flight. GABA, why you give benzos? To calm down. Glutamate, the most excitatory neurotransmitter in the body. Serotonin, mood and sleep. Okay? If you could be like one word for each one of those, this is what I would describe in essence. So remember, serotonin, the 5-HT2A, is what's added for the antipsychotics, right? So what serotonin does is increases the well-being, satiety, being fulfilled when you just had a good meal, reduce the pain receptor. Oh, this is why the SSRIs, it reduces the pain, right? Some of medications are SSRIs, it could reduces the pain. It's a lot to do with the serotonin. So where is it made? Right? The Raphael nuclei of the brain. If the answer choice is the brain stem, it is also correct because this is where the Raphael nuclei it's produced. I mean, serotonin is produced in the Raphael nuclei of the brain. Okay, so you need to know where serotonin is produced. If you think of a serotonin for well-being and mood, you think about the conditions. One that have increased serotonin, they may have serotonin syndrome. If they have decrease in serotonin, they would have depression, obsessive compulsive disorder, anxiety. Well, have you noticed that depression, obsessive compulsive disorder, and anxiety, they're all treated by SSRIs? Right? Same medication, just different dosing. Right? So when we look at serotonin, we think of Raphael nuclei, mood, anxiety, sleep. Serotonin has a lot to do with sleep. And before you ask me, I'm going to go there. Which neurotransmitter is involved with nightmare? It is complicated. Okay? It's complicated because it's both norepinephrine and serotonin. Let me give you an example. What happens when you give someone trazodone? What is the first symptoms they come back and say? Oh my God, I had crazy dreams, right? Because serotonin ungrounds you from reality. So that could lead to nightmare, right? And also, you can make the point of why do we give Prozac for someone that it's having nightmare? The same thing, because it cuts norepinephrine. Norepinephrine, right? So again, back to the serotonin, appetite. When you have too much serotonin, you have this head red fat syndrome that I like to think of. Or when you initiate serotonin, the head will be the headache. So you tell your patients, okay, initially in the first 3 weeks, you might have these symptoms of headache. Your mood may be off. You may be asocial a little bit. You may have decrease in impulsivity. You may have decrease in anxiety or decrease in sex drive. That is because of an increase of serotonin. The red is the platelet binding, so they may be more susceptible for bleeding. And the fat will be the GI motility, like nausea, vomiting, diarrhea, especially in the first 3 weeks. Right? So if they are combining two serotonergic medications, or they have an increased excess of a serotonin for whatever reason, they may again have this serotonin syndrome. You can call it by head, red, and dead, because mortality is really high, close to 10%. So they will have excessive headaches, agitation, and confusion. The red, they may have hyperthermia, hypotonia, sweating, tachycardia, and eventually death. Now, for the test, you need to know this acronym. I would put this in my dumping sheets. Is the S's, 2 S's, 2 H's, 2 D's, another 2 H's, 2 muscles, and a tick. So let's go cover this. The 2 H's for the 2 highs is for high increase in heart rate and BP. The two H's for diarrhea and diaphoresis, or the DIs, I'm sorry, the two H's will be the headaches and hallucination. The two muscles, it was muscle spasm, muscle rigidity. Okay? Now, they may have hypoflexia or hyperflexia, I'm sorry, not hypo, hyperflexia. So for the test, you need to know the difference between serotonin syndrome and NMS. So what is high yield about serotonin syndrome? Muscle spasm, hyperflexia, and what you give? Cyproheptadine. For the test, how is NMS and serotonin syndrome different? Serotonin syndrome, they have muscle spasm, muscle hyperflexia, and what you give, excuse me, is cryptoheptadine. Okay, we are going to go over NMS in a second. Now, remember, serotonin syndrome was produced in the synthesized, produced, created, made in the Raphael nuclei. The dopamine is all about pleasure, right? Remember, dope and GABA. Dopamine and gabapentin is the reasons or the receptors involved for substance use. Dopamine, it is produced in the substantia nigra, nucleus accumbens, and VTA, right? Ventral tegmental area, or you can call it very tired addict, to remember, right? You need to know substantia nigra, nucleus accumbens, and ventral tegmental area. Now, let's talk about the pathologies of dopamine. Too much dopamine in the mesolimbic postulate psychosis. Too little of dopamine, right, could cause Parkinson's disease, anhedonia, and even addiction. Right? So if you think of the dopamine, where is it created? Mainly the VTA, but you need to know substantia nigra, nucleus accumbens, and VTA, which is ventral tegmental area, right? So remember here, the inhibition of prolactin, right? The problem with prolactin, inhibitory factors, could cause, if they have an inhibition of prolactin and dopamine, irreversible countering each other, right? In the tubulofundibular pathway. Remember about extrapyramidal side effects. So if you block DTA, you could potentially have side effects. If the dopamine is blockaded in the receptor too much, then you have too much of acetylcholine, less of dopamine available, and could lead to extrapyramidal side effects. So hopefully this is all kind of coming together, or at least a review for you at this point, right? How about norepinephrine? What does it do? If you walk in ICU, my biggest panic, I think, in my entire life is running out of norepinephrine while I'm in the bathroom or taking a lunch break and my patient dying, or switching shift and having someone that depends on me to keep the heart rate up, the blood pressure up, and the pharmacy doesn't deliver my meds on time. I think that's the biggest thing that always stuck with me for ICU, right? So it's all about increased heart rate, alertness, well-being, and also decreases of pain sensitivity and circulation. So where is it made? Locus coeruleus and medullary reticular formation. So please, you need to know where those neurotransmitters are synthesized, right? Remember, fight or flight. And how is it associated? If you have too much norepinephrine, it could lead to anxiety. If you have too little, it could lead to depression. So when you talk about depression, it is not only serotonin, right? It's a lot of things. It's dopamine, it is serotonin, it is norepinephrine. Remember, locus coeruleus and the reticulars formating, the medullary reticular formation is also norepinephrine. So that is something that you need to memorize early. Okay, early, because you don't want to be trying to memorize where they are made, to synthesize at towards the end of the course, because you will get a question on this. Now, acetylcholine, if you think of increasing heart rate, secretion, sweating, salivation, memories, and muscles contraction, it's all about acetylcholine. So when one has low dopamine and too much of acetylcholine, your heart rate might be increased. There may be lots of secretion, lacrimation, lots of diarrhea, sweating, salivation. Okay? Think of ACE makes your heart race for its effect on the heart. Now, think of it, true parkinsonium or parkinsonism, the balance between dopamine and acetylcholine. If the acetylcholine is too much, right, then you have your parkinsonium symptoms. If it's too little, then you have dementia-like symptoms. Often tested is where is it made? Nucleus, main nerve is where it's based. It's basically made, and it is role in the oculomotor and autonomic nervous system. Remember, because you have too much of acetylcholine, you have acute dystonia or oculomotor symptoms. So what you want to give? A anticholinergic medication, which we discussed earlier, which is cogentin, right? Here even says, hey, if the transmission is mediated by acetylcholine, the neuron is termed as cholinergic. So you're given an anticholinergic to decrease the acetylcholine, therefore reversing or decreasing the blockades of decreasing those symptoms that are associated with the increase in acetylcholine. GABA, most abundant inhibitory neurotransmitter. Most abundant excitatory would be glutamate. If the question asks for inhibitory neurotransmitter, GABA is your answer. Because when you have GABA, you feel sleepiness, you feel a decrease in anxiety. It may even improve alertness, memories, and muscle tension, right? GABA grabs for its calming effects to help in anxiety. Now, if you have too little of GABA, again, you become anxious, right? So benzodiazepine binds to the GABA receptors to produce a biological response, which is the calming effects that we see with GABA, right? So a few things to know. GABA is relaxing, chief inhibitory neurotransmitter, right? Too much of it, Too much benzos on board, you could stop breathing, especially if they mix with alcohol. Means no anxiety and no seizures. Glutamate, most excitatory neurotransmitter, right? Glutamate, glutes are tense for excitatory effect causing on anxiety. So now think of it, glutamate is not only dopamine that causes psychosis, glutamate too, if it's excessive. Not very high yield for the test, but overall, so you can understand. Mood lability, seizures. If too much glutamine, it could lead to seizures. That's why you give something that counters that, such as gabapentin or anti-seizure medications, which decreases the glutamate transmission. Okay. All right. No wonder it has to do with memory too. It works directly and in volume with neurotransmitter. What does it volume neurotransmitter? Basically, some neurotransmitters can be activated directly and some can be activated by volume. Volume, think of it as a puff of a perfume, and it drops and kind of activates other neurotransmitters. Not very, it's something that we see on psychopharmacology, but not super high. You just want to mention that though. So in an increase in a corticotropin release hormone in the medulla, hippocampus, and locus coeruleus also could increase in symptoms of anxiety. Okay. Now, again, adrenaline, fight or flight, GABA, calming, noradrenaline, adrenaline, concentration, acetylcholine, learning and memory, dopamine, pleasure, glutamate, memory, serotonin is your mood, endorphins, euphoria, right? During exercise, excitement, anxiety, not anxiety, sex, producing well-being, euphoria, and also reduce pain. Here we go. Which brain region is the majority of serotonin neurotransmitter associated with the sleep and mood produce? Most of you guys would say it is A, right? Okay, so here we have it. Okay, now remember, nucleus accumbens would be the dopamine, locus coeruleus would be norepinephrine, and amygdala is not associated with none of the neurotransmitters, but more with fear and fear response, but primarily not but is not primarily responsible for serotonin production, right? And smells. So that you have it. Let's do one more and then we take a quick break. Let's do module 10 real quick. If you have a question, please, Jacqueline or Mavis, please ask your question while I upload the next module.
So I just had a quick question about starting someone on an SSRI. Did I hear you correctly? Will starting someone on SSRI sometimes cause them to have nightmares and then they're put on prazosin?
No.
Or no?
No. So we're starting someone on SSRI, specifically trazodone. It could increase nightmares and crazy dreams because it unbounds them from reality. Now, prazosin affects norepinephrine primarily, so it decreases nightmares. Okay.
Oh, okay.
So oftentimes you see that when you start someone with prazosin, or trazodone, they come back and say, "Hey, how's it going? You're sleeping okay?" Say, "Yeah, I'm sleeping wonderful, but I'm having these crazy dreams." What kind of crazy dreams? They are dragons, nightmares. They are. So the point that I was trying to make is that not only serotonin but norepinephrine also, yes, it also gives nightmare. Okay.
So I thought I read somewhere or something that Wellbutrin can cause a person to have increased nightmares or increased vivid dreams or something. Have you
Yeah,
heard of that?
I think you are. It is true. It is true. Both, right?
Hmm.
So if you say that, then you can say that Wellbutrin doesn't have serotonin, but it has norepinephrine,
Right.
dopamine. Because of
Right.
the norepinephrine, it could cause scary dreams. Yes. So
Okay.
in counter to that, it it's blocks norepinephrine, so therefore it decreases crazy dreams in prazosin. So
Okay.
hopefully now not only you have the knowledge, but you can see, oh, okay, this medication does this, and this one counters that, and that's why we give it. So yes, thank you for clarifying that and asking that question. All right. So now we are on module 1, training number 10. So here is about lithium. We touch base on lithium. You will likely to get 5 questions on lithium or more. So it's well worth it of your time to really understand how lithium works. Not how it works, because none of us really fully know how it works, but how it interacts with other medication, right? First thing to know, it has a narrow therapeutic window. So what does it mean? Well, it means that in practice, if someone is really manic, you may not want to start lithium right away because it has a low therapeutic window, which means you don't want to keep the patients for 2 weeks, right? You may want to start something else. And that's why oftentimes someone's manic, we say, go ahead and start with olanzapine. And then later we transition them into lithium, Depakote. Because lithium, you should not raise the levels fast because it has a low therapeutic window between 0.6 to 1.2. When it reaches 1.5 or higher, it becomes toxicity, right? It is the standard treatment for manic episodes. Again, test, reality, right? Test, standard treatment for manic episode. Why? Because it has reduced suicidal ideation and behaviors in manic bipolar patient. In bipolar patient, not borderline, bipolar patient. And it is neuroprotective treatment of choice. Do you see that all these 5 bullets are highlighted? So the standard treatment for mania, why? Is the only drug, an exception to clozaril, that has a reduced suicidal ideation or behaviors for manic patients. So questions that might ask you, which of the following medications would you has a reduced suicidal behaviors or ideation for manic patients or bipolar patients? Lithium. If the question I ask, which drug has a reduced suicidal ideation or behavior for schizophrenia patient, clozaril. Only 2 drugs. Okay. Now, it is also likely to ask why, because it's a neuroprotective, protects your neurons or the patient's neuron for those mania-like symptoms. Okay, Now, you are going to prescribe lithium. So what kind of labs would you ask for, right? What kind of labs would you ask for when you are prescribing lithium? You want to ask for your TSH level. Because when you are prescribing lithium, your TSH levels will fluctuate, likely or could cause hypothyroidism. And when you have someone that's hypothyroidism, it could mimic actually hypothyroidism, right? Is when you prescribe someone with lithium, hypo. But when you have someone that is TSH is hyperthyroidism, it could mimic mania-like symptoms. So 2 points that I'm trying to make is hypothyroidism is a side effect of lithium. But when the thyroid is hyperthyroidism, it could mimic mania symptoms. So they are not in mania, but the problem is hyperthyroidism here. Okay, two distinct relationships with the lithium here. Okay, you want to ask for your BUN and creatinine, right? Because it really tells you how the kidneys is working. Both usually together. So if you look at serum creatinine, it's the same number as the number that you would want to memorize for lithium levels. 2 for the price of 1 here. Here we go. Right? BUN levels, 10 to 20. Now, for any question on the board, if it says HCG as one of the answer choice, and I don't even care what question, be very suspect of that answer as a possible correct answer, because it has to do with safety. Ask yourself what you remember about HCG, right? It's very unlikely they would just throw HCG in any question. So if they do it, it's because there is something to do with pregnancy. And when it comes with pregnancy for the test, anyone between age 12 to 50, females, pregnancy test is high yield. Okay. You also want to ask for EKG because it could cause dysrhythmias. So TSH, BUN creatinine, HCG, and EKG. These are the tests that you might want to ask before you prescribe lithium. Now, there are a lot more. You probably want to get a CMP. You definitely want to get a CMP, right? But for the test specifically, we are concerned about these 5 labs here. Okay, labs or studies, EKG. Okay, for the test. In real life, you want to know about your electrolytes. You want to kind of know a little bit more in detail. Remember, we talked about hypothyroidism being a side effect of lithium, and hyperthyroidism mimicking mania-like symptoms. So therefore, you want to ask your TSH level. Lithium is not a weight neutral medication. Like, what are the mood stabilizers that weight neutral that doesn't cause weight gain? Anybody remembers?
Is that
Lamictal, right? High yield. Which mood stabilizer is the least weight gain? Lamictal. Lithium will cause weight gain. It will cause central nervous system defects. Fine hand tremors is a side effect. You cannot see fine hand tremors. If you can see, it's called coarse hand tremors, and that is not a side effect. That is a toxicity level. Fine hand tremors you cannot see, so it's a side effect that one might correct cells. So one might mention, right? Confusion, headaches, course is a toxicity level. Nystagmus. You may see maculopapular rashes, acne, itching, GI, diarrhea, vomiting, cramps, anorexia. You might have renal problems, diabetes insipidus, polyuria, and polydipsia, eating, drinking too much, peeing too much, and being thirsty, right? Remember how we ask for the EKG? Why we ask for the EKG? T inversions, right? T inversion, dysrhythmia, it's high yield. You should know T inversion. And it may cause hematologic issues like leukocytosis, right? Decrease in your, dysfunction on your white blood cells. So please know that. Now, if it levels reach toxicity, any question, any topic, if the question in the topic or the question says severe of any kind, please make a note that that's leading towards toxicity of any drug. You should have headaches, but if you prescribe SSRIs and severe headaches, then you're thinking of serotonin syndrome. If it's severe nausea and vomiting, then you're thinking about that drug is causing a toxicity. So exaggerated severe symptoms, they are likely cue you in for toxicity level. It could cause drowsiness, confusion, blurry visions, blurred speech. Curse, hand tremors is a sign of toxicity level. Now, actions to take, right? Is what we are concerned. Anytime you have lithium toxicity, you stop the medication first and then collect labs. If this order is inverse, it is incorrect. If you think, you dream, you suspect toxicity, stop the medication. Now, let's say a different scenario. Let's say the person is in the ED, in a controlled environment, and option A says, tell the patient to stop medications upon discharge. Option B, collect EKG. Which of the following action would you do first? Right? So collect an EKG would be the correct answer. But you just said to stop the medication first. Yes. Yes, that is the correct answer. But in this specific scenario, when someone is already in the ED, is already in the bay, is already being treated, that is not necessarily the first step for this specific scenario in this rare occurrence. Your action, anytime you have any toxicity for any medication, is to stop the medication first. Okay? Just a little nuance. If it's in a controlled environment, your priority is not to tell the patient not to take lithium anymore, but it would be to get an EKG at that time, specifically for lithium. All right? So hopefully that's clear. Well, earlier we talked about lithium and NSAIDs, ACE inhibitors, ARBs, and how it interacts with lithium. It could double, especially NSAIDs, the amount of lithium, because what it does is it retains the lithium and excretes sodium, right? So if you're excreting sodium, less sodium available, more lithium available, it could cause lithium toxicity. Remember, ACE inhibitors also treat heart failure. ACE inhibitors, okay? Now, remember about NSAIDs could double the lithium level. So what do you do for pain? How about some Tylenol, aspirin? And avoid for patients with rapid cyclic as the monotherapy, because lithium is just not effective for bipolar rapid cyclic, meaning changing of the mood rapidly throughout the years. That will be Depakote, the drug of choice as monotherapy. Please remember these drugs and how it interacts with lithium. Again, we kind of went over this, just a reminder. May I have someone that could read this question for me, please? Any volunteers? Thank you. Please.
A 46-year-old patient with bipolar disorder arrives at a routine follow-up appointment worried about severe vomiting, diarrhea, muscle weakness, blurred vision, and ataxia. The patient currently takes 1,000 milligrams of lithium daily. What should be the nurse practitioner's top priority? A, keep the patient on their current regimen since they're stable and continue monitoring. B, request an EKG. C, instruct the patient to discontinue lithium usage and arrange for a lithium level test. And then D, measure the patient's vital signs. And my own answer, I would go with C, as we just discussed. If you suspect anything, you discontinue first and then pull levels.
Absolutely, absolutely, right? So instructing the patient, because the patient is going home, to stop lithium and so forth, that would be the option, right? If the patient was in the ED, right, would be more of a controlled environment, then EKG would be the best option, okay? So very similar question, just a different environment, right? So in that case, the patient is being released. So you tell the patient to discontinue the medication immediately, and you collect labs thereafter. Do not wait for the labs to collect information. All right, so we covered a lot, and I know you guys need a break. So it is 8:40. Let's come back at 8:50 Eastern Standard Time. So roughly 13 minutes from now, I'll see you guys soon. Bring your questions. I'll come back a little bit early, but don't come back early because of a question. Take your break, please, okay? I'll see you guys soon.